Welcome to the lung infections. No, let me just correct that spelling. Lung infections. So what are the lung infections that possible? We could be pneumonia, usually fever and a cough. Other thing is that may not be a lung infection, or after lung infection, a bronchitis. It's important to know. It could be Pcp pneumonia. Could be an abscess. So we're going to talk about each one of them. So bronchitis, what is that? It's not about pneumonia. That's what it's called. Fever, cough, and sputum, productive sputum, productive phlegm. So this is what you call a fever, cough, sputum. That's what you call it, sputum. What do you do when you have that? Okay, you do chest x-ray. And then chest x-ray, there will be no consolidation. So what do you treat it with? You treat it with doxycycline or azithromycin. There's no consolidation. Pneumonia is different. That's when there is consolidation. So there are different types of pneumonia. Usually, so the pathophysiology of it could be hospital community acquired pneumonia, hospital acquired. Usually for someone who's hospitalized and on dialysis, on nursing home, also increased risk for MRSA and Pseudomonas. So this increased risk for MRSA and Pseudomonas. But what if it was a community acquired pneumonia? So it could be community acquired pneumonia. There is no hospital community acquired pneumonia risk, and usually it's the usual bugs: strep pneumo, Marexella catarrhalis, and Haemophilus influenzae. So strep pneumo could be Marexella catarrhalis, it could be Haemophilus influenzae. What if there was a Klebsiella pneumonia? Klebsiella pneumonia. Think of alcohol associated pneumonia. What if it was Staph aureus pneumonia? Think of a post-viral upper respiratory tract infection. Staph aureus, usually post-viral, can be associated with that. What if it was Mycoplasma? Think called agglutinin disease. So think of, could be associated with autoimmune disease. So autoimmune hemolytic anemia. AIDS could be PCP, could be TB, could be fungal, could be CMV. So we're going to talk about that. So what are the symptoms for that? Fever, cough, and consolidation physical exam, which means increase fremitus, increase egophony, and decrease breath sounds and dullness. So how does the patient present usually? Fever, cough. Okay. And then on physical exam, you will have increased fremitus, increased egophony, there will be decreased breath sounds and dullness to percussion. Chest x-ray shows consolidation. And the treatment, how do you treat it? If it is health care associated pneumonia or hospital acquired pneumonia, then you do vancomycin plus peptazo. What if it was community acquired pneumonia? If it was a community acquired pneumonia, then we give ceftriaxone, azithromycin, or moxifloxacin. Okay. And then what do you do for follow-up for a pneumonia? For follow-up, you want to do for pneumonia vaccine for streptococcal, and for Legionella you get urine antigen, Legionella antigen. So this is for a pneumonia. What if it was a PCP pneumonia? How do you treat that? PCP, what is the pathophysiology? Usually associated with HIV, AIDS, and CD4 less than 200. How does the X-ray present? Usually present with a bilateral, interstitial, infiltrates, and usually subacute pneumonia. Like it's not acute, it started 3 days ago or something. It's lasted like 2 weeks. So how do you diagnose that though? You diagnose it by silver stain on sputum, and then you treat it by Bactrim IV and steroid if PaO2 less than 70. What are the follow-up that you do for that? Follow-up you want to do, there will be increase in lactate dehydrogenase. There will be increase, but don't order it, you don't need that. How about an abscess? What is an abscess? Abscess actually is a necrosis of the lung. How does it present? Present with fever, like pneumonia, cough, and sputum, plus foul breath. That's important. And chest X-ray shows cavitation. So that's the difference. And how do you treat it? You treat it with antibiotic plus drainage if necessary. Sometimes abscess is hard to get rid of by without antibiotic. Basically, it's like a big group of bacteria that the antibiotic is weaker than them, so that's why we need the incision and drainage. So that's basically lung infections. So in a summary, if it's a bronchitis, there will be no consolidation. You give doxy or azithromycin. If there's a pneumonia, fever and a cough, but consolidation on X-ray, and you have increased breath sound, dullness to percussion, and everything, you give vancomycin plus peptazo if it's a hospital acquired, and you give ceftriaxone plus azithromycin if it's community acquired with risk factor. If just community acquired without risk factor, like no diabetes or anything, you give azithromycin. Or you can do moxifloxacin. It's expensive, but it's combined both. Covered. So this is for pneumonia. For PCP pneumonia, you give usually CD4 less than 200. You do silver stain and you give Bactrim IV and steroid if PaO2 less than 70. For abscess, usually there will be foul smelling and cavitation, that's extra, and then you do antibiotic plus drainage. And that's basically a summary of a pneumonia. Thank you so much for listening, and I will see you in the next one.